At this year's ASCO, I discussed the evolving roles of taxane chemotherapy in patients with metastatic prostate cancer. As you may know from last year's CHARTED study, there's been a clear survival advantage for patients with high volume metastatic prostate cancer that's castrate resistant who receive docetaxel plus androgen deprivation therapy in comparison to androgen deprivation therapy alone. It was over a year survival advantage. At this year's ASCO, there's a number of studies that are reported that basically support this state and support the concept of early chemotherapy, which speaks to the evolving role of docetaxel in patients with castrate-sensitive or hormone-naive prostate cancer. One of the posters that I discussed was a study which began in 2007 that looked at men with prostate cancer after radiation therapy who had a rapidly rising PSA with a doubling time of less than 9 months and a PSA greater than 1. In this randomized study, patients were randomized to androgen deprivation therapy, or ADT, versus docetaxel plus ADT. And although this is a small study with a short follow-up, there was an improvement in progression-free survival in patients who received chemotherapy. Again, this speaks to the fact that there's been a number of studies that suggest early use of docetaxel chemotherapy improves survival in patients with castrate-sensitive prostate cancer. Now, in the area of castrate-resistant prostate cancer, I reported and discussed a number of studies that involved the combination of docetaxel plus other agents. One of them was a subgroup analysis of patients treated on the Custirsin Synergy trial. In that study, patients were randomized to docetaxel versus docetaxel plus Custirsin. In that trial, there was no difference between the two arms in the entire group. But what the authors did is they called out retrospectively or post hoc analysis looking at patients they identified with poor risk criteria and showed in that poor risk subgroup there was an improvement in overall survival, suggesting that there may be a role for this drug in combination with docetaxel if you could identify the right patients. The second trial was a combination of cabazitaxel with carboplatin, which is a taxane plus a platinum. Again, in this trial, they also had a subgroup, but this was prospective, of patients with poor risk prostate cancer as defined by the investigators. And once again, they showed that the combination had a much higher response rate and improvement in progression-free survival in the combination arm. So these two studies suggest that if you can identify the right patients or the poor risk patients, the addition of another agent to docetaxel chemotherapy will have a benefit for the patient. This still needs to be proved in a prospective randomized phase 3 trial. The final abstract was a very small study of a combination of a docetaxel plus radium-223 versus docetaxel alone, again in the same space of castrate-resistant prostate cancer. The response rates were about the same in both arms. The combination was safe, which was good to see. There wasn't increased myelosuppression. And there was a normalization of bone alkaline phosphatase, which is a marker of metastatic cancer to bone, in patients who received the combination versus those receiving docetaxel alone. And that occurred in over 90% of patients, suggesting maybe there'll be a more durable response. Follow-up is very short in this study, and it's hard to make any conclusions except that this is an interesting combination, and again, on the theme that how do we make docetaxel better in patients with castrate-resistant prostate cancer. I think the future will be about identifying those patients. In the presentations that were presented and discussed, it was mostly clinical criteria, but I really think we need to go to molecular criteria, so it's probably going to be a combination of molecular analysis as well as clinical characteristics that will identify the patients that will respond to these combination therapies.